Good afternoon, and thank you for joining the RLS Foundation's webinar titled Cannabis and RLS. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. The surge in use of web-based programs during the COVID-19 health crisis has created a strain on the system. If you are experiencing technical difficulty, switch to the audio portion of the program. It is the telephone number listed on your invite. It uses less bandwidth, and make sure that you turn off your webcam. We thank you for attending and appreciate your patience and understanding with any technical difficulties that may arise during today's webinar presentation. Before we begin, please be aware that all attendees will remain on mute during the hour. We thank you for the questions submitted with your registration. Today's presenter, Jacqueline Brainbridge, will answer as many questions as time allows following the presentation. After the webinar, we will receive an email with a link to the webinar recording. Dr. Bainbridge serves as a clinical pharmacy specialist at the Anschluss Outpatient Pavilion Neurology Clinic, an extension of the neurology residency teaching program at the University of Colorado in Denver. She is also a professor in the Department of Neurology at the University School of Medicine and teaches at the Skaggs School of Pharmacy and Pharmaceutical Sciences, where she was awarded Professor of the Year for 3 years in a row. Dr. Brainbridge manages patients with multiple neurological diseases such as epilepsy, Parkinson's disease, multiple sclerosis, migraine, and restless leg syndrome. She is currently involved in a cannabis research study funded by the Colorado Department of Public Health and Environment. In her past, she has had projects funded by the NIH spanning subjects such as epilepsy, multiple sclerosis, and neuroprotection trials in Parkinson's disease. Dr. Bainbridge also serves on the Foundation's Board of Directors. Dr. Bainbridge, I will now ask you to begin your presentation.
Thank you so much, Carla, and all of you guys at the Foundation, Clara, et cetera, for putting this together and making this possible. So, as Carla mentioned, my presentation will focus on medical marijuana / cannabis, and I've entitled this "The Proof is in the Pudding," meaning what does our clinical research really show us when it comes to using cannabis in patients with restless leg syndrome, or RLS, as I will abbreviate. I want to just make a disclaimer. I usually steer away from using the word marijuana. And I'll tell you the reason for that is I was giving a presentation to a group of lay individuals, so consumers or patients with medical conditions using cannabis to treat those conditions. And they really said that they don't like the word marijuana because it has a negative connotation. So oftentimes that's more viewed as people wanting to get high, and so it's just more of a recreational term as opposed to cannabis, which they felt had more bearing or weight bearing or credence as it applies to patients with medical conditions. So onward. I really, the only disclosures that I have are my research with GW Pharmaceuticals. And now that actually is only the fact that GW Pharmaceuticals is giving us medication for one of our clinical trials. So our agenda will go briefly through an overview of RLS and its treatment, and then cannabis. We'll talk about the components of cannabis. We'll talk about different forms and if they're used for neurologic conditions, which ones, and what other conditions do we see that there's legislation surrounding for medical use. And then we'll talk a little bit about, research and federal laws and guidance for cannabis use. So let's begin with RLS and cannabis. As we know, restless leg syndrome, or RLS, is a common underdiagnosed but treatable condition. And symptoms can be different for different individuals. You can see in some people you have pain, in the legs or extremities, or a funny feeling, a sensory motor um, uh, feeling. So sometimes that's creepy crawly legs, sometimes that's a pulling on the legs or extremities. We do know that this is a neurologic condition, and it's associated with decreased sleep. The prevalence is pretty broad, anywhere from 3 to 15% in the general population. We know that the incidence will increase as we age. More common in women somewhat than men, at about a 2-to-1 ratio. Pregnancy, you can actually see in the third trimester up to about 35% of women experiencing restless leg syndrome. And the diagnosis is based on clinical features and some backup of laboratory monitoring, but there's not a blood test that will tell us if someone has restless leg syndrome. This next slide is really a list from consumers like you all that report a description of how your restless leg syndrome makes you feel. So we have the creepy, crawly legs, the heebie-jeebies, the Jimmy legs, the gotta move legs, tugging, pulling, Elvis legs, etc. So thank you for that list. Non-medical therapies for restless leg syndrome, really it's identifying some of the triggers. As we know, caffeine can be a trigger for some individuals. Some of it is over-the-counter medications like cold medications, etc. But identifying what might make your restless leg syndrome worse and then trying to eliminate that. Obviously, good sleep hygiene is part of this whole equation. But we know that's very difficult if the restless leg syndrome is not under control. Moderate physical activity is good. Strenuous physical activity is probably not so good. Some people also report that hot baths or massage or acupuncture may be helpful for their restless leg syndrome. Also, if you engage your mind with meditation and yoga, that's also very helpful. So medical therapy, we know first-line therapy are a group of medications called the alpha-2 delta ligands, such as gabapentin or pregabalin or Horizon, which is gabapentin and a carbil or a prodrug of gabapentin is first-line therapy. We then have the dopamine agonists, the rotigotine patch, ropinirole, pramipexole, although we know that there's some baggage with those medications. And what I'm talking about is they can cause augmentation and frequently do. So we like to start with other therapies first. We know that benzodiazepines and opioids are very effective, but they have some negative connotation that comes along with them, and they can be dangerous if mixed together. So that's not a good starting place. Iron supplementation, especially if you have iron deficiency anemia or low iron stores, that would be your first line therapy in that situation. Levodopa, carbidopa in any of its forms, that kind of goes along with the dopamine agonist, not a good starting place. And then we have other medications such as our anti-seizure drugs or cannabis type products. So let's talk a little bit now about cannabis, since that's what we're all here for. We know that cannabis is a plant that contains over 400 compounds, actually closer to 500 compounds within the entire plant. Over 100 of the cannabinoids have been isolated. We know that there are terpenes contained in the cannabis plant. We don't know exactly what the medical benefit of the terpenes are to this point, but there is research ongoing to find out if there are any medical benefits with the terpenes. So terpene is really what gives the plant the odor or the smell, so the nose to the plant. Sometimes it can smell kind of piney, sometimes it's kind of skunky smelling. And those are due to the terpenes that are contained in that particular plant. When we talk about cannabinoids and the terpenes, we know that that's found throughout the plant. So the stalks, the flowering, tops, buds, etc. We usually talk about the cannabis plant and we kind of generalize. We talk about indica and sativa. As my students have educated me, they taught me that indica is more Inda the couch, so more sedating, and sativa tends to be a little more uplifting. But now it's really sometimes difficult to find pure strains of either one. So a lot of them have been crossbred. So there's no generalizable characteristics of the plant. Now, some companies will have pure sativa and indica, but most often you'll find a crossbred group of cannabinoids or cannabis. We know that cannabis has been used for a long period of time. So if you go back and look at the medicinal purposes, it was documented in 400 AD, the use of cannabis. And cannabis was actually mentioned in the United States Pharmacopoeia, or USP, in 1850. It was subsequently removed some years later. Now, when we talk about cannabis, the two cannabinoids that are the most abundant and get the most attention. So the first one that we'll talk about is delta-9 tetrahydrocannabinol, or THC. So the other one that we talk a lot about is cannabidiol, or CBD, and I'll differentiate these two. Now, there are other cannabinoids that are also found in the cannabis plant. And a lot of those cannabinoids, such as CBG or CBN, are under clinical investigation for their medicinal purposes. So we know that THC gives you the high feeling, or a euphoric feeling. So I try and talk about it in a euphoric way, as opposed to a psychoactive way, because both THC and CBD are psychoactive. Just one makes you feel high or euphoric, and the other one doesn't. So what's the mechanism of action? We know that THC is a partial CB1 agonist. We'll talk more about that in a few slides. The beneficial effects that we know of with THC is really helping to prevent nausea and vomiting due to cancer chemotherapy. And we know that it increases appetite in some individuals, and may have a role in other medical conditions. We have adverse effects that we see with THC, so we usually chunk them into short-term or long-term. In the short term, we find that patients can have memory loss, or an impaired coordination, so lack of coordination. We also find that, and very importantly, that THC can increase your heart rate, and that can be dangerous in some individuals. We know also that it affects how you're thinking and your mood. Some individuals will also see panic or delusions, hallucinations, paranoia, and even psychosis. We see that many of our hospital visits are due to the psychosis that some individuals will experience with THC, especially if you're eating or consuming by the edible method THC. Long term, we know that there is an addiction rate. Overall, it looks like about 9%. It may be slightly higher in the adolescent population. We know that it also can impair your cognitive effects. It can actually lower IQ points by about 10 points. There's also something called a hyperemesis syndrome. It's usually seen when people are consuming a lot of THC products. Usually it's related mostly to smoking the product, and it's seen with a habitual pattern. So the problem with this hyperemesis syndrome, so violent nausea and vomiting, is that most of our antiemetics don't work for this syndrome. But I can tell you anecdotally that some individuals will respond to a topical capsaicin cream on the abdomen. When we talk about the other cannabinoid in abundance in the cannabis plant, we're talking about cannabidiol, or CBD. So with this particular agent, you see that the beneficial effects is that it doesn't increase your heart rate. So it doesn't have an effect on your vital signs or negatively on mood. So there's no significant neurologic effects. It can increase sedation, and oftentimes that's what individuals are consuming CBD for, to help them relax or calm down or even get to sleep. We know that CBD does not have a direct effect on the CB1 or CB2 receptor in the brain, but it has an indirect effect, usually with anandamide or other endogenous cannabinoids in the body. We'll talk more about that in a little while. Some of the adverse effects can be sedation. We know that it can decrease appetite, so that would be something to be aware of if you're consuming CBD on a regular basis. Also diarrhea and some nausea, and also an increase in liver function tests. So that's tests that we use to monitor your liver. You also can see a risk of infection, and that is really mainly in people who are immunosuppressed. Now there's something called hemp, and I think we need to differentiate that from what we've just spoken about, the THC and CBD. So federal law defines industrialized hemp as product that has no more than 0.3% of the THC product, or delta-9 tetrahydrocannabinol, on a dry weight basis. So that's a really important differentiation between hemp and our cannabis that we've just spoken about. To produce industrialized hemp, you have to be registered with the state and the USDA. Now, marijuana plants, so we're talking about for recreational use or medicinal use, we usually find those plants grown inside. So you're regulating the temperature, the humidity, CO2, oxygen levels, light. And the whole reason that some people who are producing these plants, they do so because they want to maximize the THC concentration. Now, when we grow hemp plants, the hemp plants usually are outdoors, and they are just kind of left to go wild because you want a big size product. So you want it to, get a lot of sunlight, not controlled, but just what's ambient. And those plants get much larger and much bigger. And the reason that I differentiate is because you're not wanting to maximize THC in those hemp plants, because remember, it can contain no more than 0.3% of THC in hemp. Another differentiation is hemp oil. How does hemp seed oil differentiate from CBD oil? Well, number one, when you get hemp oil is completely different. It doesn't have a euphoric effect. It's actually extracted from hemp seeds, and they should have that listed as the active ingredient. Now you'll notice that hemp seed actually is, you can eat hemp seed without it being a problem, because remember, it doesn't contain THC. It's really important though, if you're buying a CBD oil, when you get the CBD oil, you should look at the certificate of analysis that comes with that particular product. So you should have on the bottles a lot number or a batch number. So you should really go to the website that sells that particular product and look up the batch number. And I say that because you want to make sure that if you're taking a CBD oil, it doesn't have a bunch of THC in it. And this is an unregulated business. So oftentimes you'll find that there is THC in that CBD oil. So it's not a pure CBD oil. Now, differentiating from hemp oil, CBD oil is much more expensive than hemp oil. A lot of times manufacturers will have it listed as a CBD oil, but if you notice on the certificate of analysis or on the bottle somewhere, they might be substituting hemp seed oil for CBD oil, and that should never be the case. Remember, hemp seed oil is going to be much cheaper, and there's no euphoric effect. There's no THC. This is just a slide for your edification. It's really the difference, again, between hemp and marijuana. And it talks about a psychotropic effect or not. Again, I use euphoric or non-euphoric. And what regulatory agencies oversee the hemp and marijuana. So marijuana, we're looking at the DEA and FDA. Hemp, we're looking at USDA and FDA. So federal laws, what's the big deal with getting research moving along with these particular products, moving the products from state to state? And it all boils down to the fact that marijuana is still by the DEA, a Schedule I drug under the Federal Controlled Substance Act. So it makes it possession, purchase, sale, etc., illegal. So other drugs that are a DEA Schedule I agent would be gamma hydroxybutyric acid or GHB, MDMA or ecstasy, LSD or lysergic acid, and also heroin. So this particular slide, we have to update this all the time because this is the legal status of cannabis across the United States, state by state. And you can see there are only a few states that have held out, and cannabis, at least at the last time I pulled this up, were fully illegal. And you can see the slides that have legalized cannabis or marijuana, medical or decriminalized, just medical and decriminalized. So there are a number of states with various approved medical conditions, and this slide might be a little bit out of date, but these are the individual states that had some legislation surrounding these medical conditions and the use of cannabis. So if you notice epilepsy or seizures, there are 28 states that have legislation. My guess is that number has increased. I would almost say that we should be up to about 50 since we have an FDA approved product to treat epilepsy or certain kinds of epilepsy. But then you see that multiple sclerosis had 30 at the time of this this publication, or when I looked at it. Parkinson's disease was at 30. This is from the same article, and these are not up to date because this is actually a picture. But one thing I want you to notice that at the time of this publication for cancer, now this is treating a tumor effect with cannabis, so cancer effect. There was only one pilot study with 2 patients in it, so it was preclinical work. So was the indication appropriate? Probably not, right? Because there wasn't enough evidence showing an anti-tumor effect. But there were 25 states at the time of this publication that actually had written legislation or guidance as to giving a medical card or whatnot for treating cancer. And then seizures at the time of this publication, there was weak evidence, small randomized controlled trials. So it was possibly appropriate that we had 24 states, but not enough evidence as a first-line agent. Now that has changed because we have large clinical trials now that we know of using Epidiolex to treat certain types of seizures. And this is basically just for your edification. It's the rest of that publication looking at approved medical conditions for using cannabis. There are many forms of cannabis, as you all are probably aware. There's leaf or the plant material. You can eat that You can smoke it or you can vaporize it. For our clinical trials, when we're using plant material, we use vaporization. Smoking the product is not healthy because it has combustibles around, the paper that people roll the leaf product in, etc. So we always recommend a vaporization method, and that's what we use in our clinical trials. And then there are also the edibles. We'll talk a little bit about that. There's also plant resins, oil extracts. One product that we will talk about is a nabiximol, which is Sativex, and that's a 1-to-1, almost 1-to-1 THC and CBD blend. It's an oral mucosal spray that is actually on several states, not several states, several countries has approval in those countries for the treatment of spasticity, so such as multiple sclerosis spasticity. And then there are single molecule preparations. We'll talk about these products briefly in the next couple of slides. So THC products are dronabinol and marinol. And then a chemical variant of THC would be sesamat or nabilone. And then there's a liquid formulation, which is Epidiolex. This is FDA approved for the use in certain catastrophic epilepsy conditions. And it's purified. We'll talk about that. These are just some of the a picture for the visual learners of different preparations with cannabis. Very important to know that the way you consume these products are going to affect you differently. So we'll talk about smoking and vaporization together. You can see that the burn on smoking starts at 800 degrees Celsius or 1470 degrees Fahrenheit. If you're looking at vaporization, you're looking at about 315 Fahrenheit. In our clinical trials, we go to like 393 degrees Fahrenheit to create the vapor from the plant material. When you're creating smoke with smoking, again, that's combustibles and a health hazard. For both smoking and vaporization, you can see that you have effects about after 10 minutes of starting to ingest this particular product, and the product feeling will last about 2 to 3 hours, and that's going to vary it'll be different in different individuals depending on how your tolerance is to medications. Eating, very different. So now when we're taking the edibles, you actually move to an intermediate product, which is a 10 or an 11 hydroxy THC, which is actually stronger than the regular THC. You really won't get effects until after about 60 minutes, but your effects will last 4 to 8 hours, which can be really problematic if people are eating a cookie and the directions on the cookie say to piece it up into like 16 pieces or 10 pieces, depending on the size. And then you're supposed to take one small bite and then wait for like 20 to 30 minutes. I gave a talk in Scotland and I basically said that that's not how we consume cookies in the United States. It might be in Scotland, but in the United States, it's always more like one cookie, two cookie, more cookie. And that's where people get into trouble and end up in the emergency room with psychotic events, hallucinations, etc. The other thing that I want you to be aware of, because this is an unregulated industry for the most part, is that this is one study that was published in JAMA, and they looked at 84 CBD products tested for label accuracy. And you can see only 31% had accurate CBD content within 10% of the labeled value. Many, we're talking like 43%, CBD content exceeded what was on the labeled value, so it was under-labeled. And then about 26% were over-labeled, so CBD content was below what was on the label. Again, I'm going to recommend that people go back and look at the certificate of analysis, which you may have to obtain from a website from where you purchased the product or the company that produced that particular product. Also, THC was detected in 18 of the 84 samples tested. And remember, these were basically labeling for CBD products, the non-euphoric product. So they should not have contained THC. You also have to think about contamination of these particular products, especially when we're talking about the plant material. So the FDA and EPA have not really provided any guidance on how to regulate contaminants on cannabis-related exposures and what's considered safe. So the states, it's left up to them to determine on their own how they're going to regulate this. So we're talking about chemical solvents that are used in the extraction process. We're talking about microbial contamination, pesticides, insecticides, and metals in the product. So we know cannabis is a hyperaccumulator, so metals like to attach to the product. So basically ensuring the quality of CBD products or any product really. Many of the states have a third-party testing situation. So again, looking at that certificate of analysis, making sure that the potency is accurate. So what you think you're consuming is actually in the particular product. And it also will talk about some of the contaminants and how the products were extracted. Also, you know, if it's labeled as organic, is it really organic? And then choosing a brand. For consumers, we talk to them about following and looking for products that utilize best practices or GMP certified laboratories. And those are questions you can ask of your bud tender or look online to see if the lab actually has those certifications. And then is there a support team to answer questions if you were to have questions about a specific product? And all products, no products are allowed to have health claims associated with them. So the DEA has really, issued letters to many different companies for making health claims, and they've been charged for making those claims. So now here are FDA approved products. So as I mentioned, dronabinol is a synthetic THC, that's Marinol. And it was actually FDA approved in 1985. It's a Schedule 3 by the DEA. So the DEA scheduling goes from 1 to 5, 1 being illegal substances or no medical conditions that can be treated by those substances, and then a Schedule 5 would be something like Valium. So this product is actually labeled for anorexia in patients with HIV/AIDS or nausea and vomiting associated with cancer chemotherapy. Epidiolex is CBD, so it's cannabidiol, and I always talk about Epidiolex as Epidiolex, even though it's the brand name product. And it's a CBD product. I don't want you to confuse the fact that Epidiolex as CBD is the same as CBD that you may be getting online or you may be getting from a dispensary, etc. They're not the same. This product has gone through randomized controlled clinical trials, which those are the most rigorous clinical trials that you can put a drug through for testing. This is plant derived. It was scheduled as a Schedule 5 when it first came out on the market in June of 2018, but now it is descheduled by the DEA. So we know exactly what's in this product. We know if you give 5 mLs of this product, we know exactly how much CBD is in that particular product. And it has FDA approval for some catastrophic epilepsy conditions. Sesamed is Nabilone, FDA approved in 2006, and it's a synthetic cannabinoid. It's a Schedule 2, and it's used for nausea and vomiting related to chemotherapy. Sativex, or Sativex, is almost a one-to-one THC and CBD product. It's an oral mucosal spray, not FDA approved as of yet in the United States, but is licensed in many other countries like the UK. This is used for spasticity, especially multiple sclerosis related spasticity. The University of Colorado will begin a clinical trial for MS spasticity hopefully in the next few months. So who uses cannabis and why? As you can see on the x-axis, we have lifetime prevalence, past year and past month of different groups of consumers who are using cannabis products. And then on the y-axis, we have percent, and that's the percent or trends of prevalence of marijuana use. And this is 2018 data or prior to. And if you look across the board, you can see that the 18 to 25-year-old groups of individuals are the ones that have consumed the most cannabis in their lifetime, although they haven't been alive that long, but also catching on quickly. They've used it in the past year and past month. So cannabis use, this is from one article from 2020. The average age was about 40 years of age. About 54% of the individuals using cannabis were males. A majority of them were Caucasian. 67% of patients reported cannabis experience prior to asking for a medical card. The primary medical conditions that people use cannabis for are pain, anxiety, and PTSD. In another study that you'll see below, it was pain, anxiety, and sleep. And the average number of comorbid conditions reported from people who are using cannabis was about 2.7, so almost 3 medical conditions or comorbidities. CBD and THC. So I mentioned that we have a system in our body that we call the endocannabinoid system. So we know that CBD actually enhances one of these cannabinoids, which is anandamide and other endocannabinoids in our body. And that's actually how we elicit a response for CBD. So we're looking at those naturally occurring endocannabinoids increasing when we expose those individuals to CBD. So as I mentioned, CBD does not directly bind to the CB1 or CB2 receptor. In other words, we're having anandamide do the binding at the CB1 receptor. And we know that CB1 receptors are actually found predominantly in the central and peripheral nervous system. So that may be why we might think that CBD could be good for sleep or epilepsy, such as Epidiolex is CBD. And CB2 receptors are found primarily in peripheral tissues and the immune system. So we have to think about cannabis pharmacodynamics and pharmacokinetics. So essentially, THC will interact directly with CB receptors. We know it produces a euphoric effect. And we've kind of gone through most of this, but there are recent research trials that are looking at the true mechanism of action of cannabis, both THC, which we know more about THC, and CBD. So it's exciting to know that there is more research on the mechanism of action for CBD. And what they're showing is that there may be other receptors besides the CB1 receptor involved. So it could be an opioid receptor, a G protein, or G protein coupled receptors, et cetera. And then when I go through Epidiolex, this is actually the mechanism of action that is now in the package insert for Epidiolex. So we know that in addition to CBD interacting with anandamide or endocannabinoids that we have in our body. And by the way, I forgot to mention that the endocannabinoid system in our body is really looking at maintaining balance in our body, so homeostasis. So here are some of the other mechanisms of action that are now in the package insert for Epidiolex. So we know that CBD can block the GPR55 receptors. We know that it desensitizes the TRPV1 channels, all increasing calcium and extracellular adenosine. So, and then we also find that it can inhibit adenosine reuptake pumps. All of this together will decrease neuroexcitability and again, make more of a homeostasis or a balance between what's happening in our body. So cannabis activity at the CB1 receptors. So we know that both THC and CBD work at those CB1 receptors, only CBD is an indirect effect. So if you look across the board, and these are different structures in the brain on the left-hand side. So if you look at the hypothalamus, so your THC effect on the hypothalamus is to increase appetite, but CBD has the opposite effect on appetite. So it will counterbalance what THC does. And then if you look at the brainstem, that's where you have the anti-nausea effects of THC. And again, CBD really doesn't have the anti-nausea effect. As a matter of fact, sometimes it's either negligible on that effect, or sometimes it will cause some nausea in some individuals, and so forth. Now, as I mentioned, we know more about THC, so we know what a typical dose is, but CBD is a little bit different. So it really, if people or consumers are going to try CBD, depending on what product they're looking at, we always have them look at what the manufacturer recommends, and then starting at about a quarter of that dose. So a low dose is thought to be less than 300 milligrams. However, a typical response may be seen for some products at 600 milligrams. So really, we don't know about the dose of CBD at this point. THC, we know a low dose is less than 7 milligrams, medium is about 7 to 18 milligrams, and high dose is greater than 18 milligrams. We do know that with THC, you will see a habitual pattern. So the more you use, consume, and the more frequently you're doing that, the more that you need to continue to do that. So as I mentioned, Epidiolex is cannabidiol or CBD. It's a purified product. It's derived directly from the cannabis plant. And it's an oral solution. We know how to dose it. I will tell you that there is a small amount of THC in this particular product, and that actually can be a larger dose of THC depending on how much of this particular product someone is actually taking. So it can be a substantial amount. Now, in saying that, it's important to know that people, when they're consuming, even when they think it's just a pure CBD product, can test positive for cannabinoids in the urine, on a urine sample. So just a few warnings, and I always go back to this package insert, and that's why I've included it for Epidiolex or CBD, because a lot of this information isn't readily available except for places like the package insert. So we know that you can see an elevation of your ALT and AST, which are your liver function tests. Most of the time that resolves when you decrease the product or remove the product, meaning Epidiolex, or you can use that synonymously with a CBD product that you get from a dispensary. We do know that there are drug-drug interactions. So Epidiolex is metabolized by the cytochrome P450 system, or isoenzyme system 3A4 and 2C19. So we know that several medications utilize that pathway for metabolism. So you're going to see serum concentrations increasing or decreasing depending on what product it is. So it's always a good idea to ask your pharmacist if your medications that you're taking may have a drug-drug interaction with a CBD product or a CBD and THC product. There are specific interactions that we look for with Epidiolex. such as with valproate or valproic acid or Depakote. So we know that you'll see more of those liver function tests increasing. So that's more of a pharmacodynamic effect, and it can be an additive effect. And then we have pharmacokinetic effects with clobazam and rafinamide, eslicarbazepine, and topiramate. So what's happening on the research side? Well, on the research side, there's really a lack of research done in the United States because these products are Schedule 1 by the DEA. So we really have to look at other clinical trials to make decisions as to if we think it's going to work for a specific indication or medical indication. We also look over the pond to Europe and Canada to see what is happening in their neck of the woods. So in regards to RLS, really there's not a lot of great research, really any research out there. So we have to refer to studies that have conditions that are somewhat related to RLS. So we look at sleep, we look at pain, and see how people did with those particular conditions. I will say that we need more research. That's what we need. So here's what's out there. There are two reports of cannabis for restless leg syndrome. So this particular one, excuse me, is a report of 6 patients. So this is something that we call observational data. So it's not a randomized controlled trial. This is actually patients who reported using specific products and what was their condition and what were they on and what was their response. So if you look down here, 100% of the patients that used cannabis had a relief of their restless leg syndrome. And many of them were on traditional medications to treat restless leg syndrome, either in the past or currently. This is a follow-up, same group. So now there's 12 patients that are added to this particular observational deck. And you can see that many of the patients were on traditional medications for RLS. And most of the patients had a response after smoking marijuana. But again, it's not a consistent marijuana product. If you look at like patient 2, they did not have any response at all to the cannabis product. So it's very variable, and I can definitely tell you that's how it is across the board. If you look at anxiety, so using CBD may be a place to start, and it might be an okay product to try for people who have anxiety. So this particular trial is someone who had who has a social phobia, anxiety, so to public speaking. So that's what SAD is, social anxiety disorder. So they looked at 12 patients, they got 600 milligrams of CBD, or 12 patients with placebo, and then 12 patients who were healthy controls without social anxiety disorder. The intervention or the study procedure was to give the CBD capsules 90 minutes prior to the simulated public speaking test. And what they found was that CBD intervention significantly lowered the symptoms and negative self-assessment of subjects with social anxiety disorder to levels near that of healthy control individuals. So CBD may, excuse me, I'm going to sneeze, may be an appropriate agent to use for anxiety. Now the dose is still, you know, it depends on the product. Again, we can't say 600 milligrams across the board. Here's another trial that looked at anxiety and sleep, and this was a large case series. So they used patients who were in an adult clinic, so an adult psychiatric clinic with a diagnosis of anxiety or sleep disorder. There were 72 patients total, 47 had anxiety and 25% had, or 25, not percent, but 25 had a sleep disorder. And what they did is the intervention was, or the study procedure was to give 25 to 75 milligrams per day for the people with anxiety, and that was 1 capsule in the morning. If someone had an issue with sleep, they took the capsule at HS. So this was in conjunction with their regular psychiatric medications and regular visits. And what they really found at the end of this study is that CBD may hold benefit for anxiety-related disorders. And it also looked positive or somewhat good for sleep score. So there was it didn't meet statistical significance, but patients may have felt a little bit better, at least initially, for sleep with CBD. So the remaining questions really are, what dose do we use? What formulation? What route of administration? Do we need a combination of cannabinoids? Do we need a THC with the CBD to counteract some of the effects? When we look at sleep, is it really falling asleep or staying asleep? And how helpful is it with RLS-related sleep issues? What adverse effects might we see long-term? And can CBD or THC replace current therapies, or should it really be used in conjunction with other medications? And I know you all submitted questions, so we'll go through some of this. I will tell you right now that THC actually helps people initially get to sleep, but then they wake back up. It's kind of like consuming alcohol. So it becomes an irritant after you've taken it for a little while. It also oftentimes will lead to a habitual pattern. So, oh yeah, that worked, and I just started going to sleep, and it was working pretty well, but now I have to increase my dose, or maybe take it a little bit earlier and later. So THC is probably not the cannabinoid that we're looking at for the best sleep. CBD would be a much better option in that arena. Now, I will also tell you that they're looking at CBN also for sleep, but we do not have that information now. So this is just some of my acknowledgments, some of our older study team. We're hoping to up-ramp a clinical trial for RLS. We've actually been, we have been denied funding at least twice for the condition of RLS. So we're hoping we have protocols written, and we're hoping to get this off the ground in the near future. So some of the frequently asked questions, how can I get medical marijuana in my state if a doctor prescribes it? I would say that you have to go by the laws in your state, and you certainly cannot carry these products across state lines. So I would urge you to look at the legislation in your particular state. Does cannabis-based oils do anything? Well, the answer is yes, probably. As a matter of fact, I was speaking to someone 2 days ago who has utilized topical cannabis product, either in a balm formulation, but a balm formulation is kind of greasy, but now has it in a cream formulation, and it tends to work really well for that individual. And is marijuana effective in treating RLS? Well, anecdotally, I have a handful of patients who have used it, have come off opioids to treat their RLS. I would encourage you that if you're one of those people, or you've found any cannabinoid helpful for your RLS, can you please email me about that? So we're trying to write a little bit of an anecdotal article looking at the anecdotal effects of RLS and treated by cannabinoids. How can you be involved for studies? Hopefully our study will get off the ground someday in the near future. But you can always check clinicaltrials.gov, and that all clinical trials need to be registered there. is there research being done? Not that I know of in RLS. So anyhow, I think we will open it up for questions at this point in time. We do have several questions that you guys have submitted, and I'm happy to talk about those.
Okay, thank you, Jackie. We'll start with the first one. Are there any contraindications between the methadone that I take for RLS and cannabis?
Contraindication. So that's interesting. So cannabis, so we have to think about CBD is going to be pretty sedating. THC is also going to be sedating. And there are going to be potential drug interactions with that methadone, especially increasing something called the QT interval. So that can be problematic. So I would recommend that if you're on methadone and you're wanting to try a cannabinoid of any flavor, I would ask for guidance from your healthcare provider, preferably your neurologist, or engage your clinical pharmacist.
Are there any dangers in using cannabis and dopamine agonists? Are there any effects on dopamine receptors in the brain?
So, well, dopamine is a feel-good neurotransmitter, so we have to just say something about that. So my problem would be shoes, as many of you all know. But when we talk about the dopamine agonist, there's no drug interaction that's of the pharmacokinetic variety. That means interfering with the metabolism through the liver or in the brain. Now, pharmacodynamically, as we mentioned, these products can cause sedation. So if your dopamine agonist is already causing sedation, you will most likely feel more sedation with the cannabis type products.
Okay. So any effects on the dopamine receptors that, like, I'm not sure if they're meaning, does it damage them or does it somehow change the way that they function?
So I don't think that we have the research to back that up at this point. So we don't know anything except for it's the reward system. So dopamine's involved in the reward system. So you might see a slight down regulation of those receptors, but I don't know that that's actually been proven.
Okay. Can THC oil and CBD used in children in which, so they're asking ages 13 to 15, and have there been any studies on this subgroup?
Well, the one study that has been done is Epidiolex. So Epidiolex is approved for catastrophic epileptic conditions that are mostly found in the pediatric population. Now, outside of that, I would not be giving THC to someone in that age range because we know, number one, it's addictive, especially if you're looking at a male. The frontal lobes really aren't fully developed until about age 26. So I usually show a slide, but many of you have heard this presentation before, so I didn't include it, but it looks at, again, it's the reward system, dopamine, and they don't have the capability of stopping to use the product or saying enough is enough. Whereas adults have a better ability to do that. So I would certainly not be giving THC to someone, in their teenage years, unless it was for, something like a catastrophic epilepsy. And then I would be looking for guidance from your neurologist. So it's not a good drug for the brain, THC.
Can you mix cannabis and oxycodone together, and can it help you lower the amount of oxycodone that you use?
The answer is yes, and potentially yes. One of my anecdotal patients, we together, I mean, he's just an amazing, smart gentleman, and we were successful at getting him off of oxycodone onto a CBD type product. So the potential is there, yes. I would say if the opioid, the oxy is sedating, and you add a CBD product to that, you may have more sedation. You know, some potential for some drug interactions there as well. But it can be done, and it can be done safely. We have a clinical trial that will be starting here soon, looking at patients with back pain. And we'll have one arm where the intention is to get them off of their opioid onto a CBD or THC CBD product.
Okay, how are we doing? See, I'm going through these questions. Is there any research on Delta 8, THC, and RLS?
No. And
No.
Delta 8 is kind of, it's probably has a little bit less potency than Delta 9, but people are finding it as kind of a loophole for trying to say that some of these products are legal because Delta 8 is not listed in any of the legislation. So I would stay away from Delta 9 because there are going to be, or Delta 8, because there are going to be other effects that we don't know about. And people are cooking this stuff in their kitchen. So it's not a robustly available product from a reputable source. So I'd stay away from Delta 8.
Is there any evidence that cannabis worsening RLS?
There, I'm stumped. I haven't heard it. I have not heard of somebody's RLS getting worse. I would say that, again, CBD is probably going to be more of the product that you're looking for. Now, it might be that you have to have a little bit of THC with that CBD to see efficacy, but that's what we need to find out with our clinical trial.
And then last question, is there any evidence that cannabis can help with sleep, whether the issues are RLS related or not?
So remembering to stay away from THC, CBD may be more of the product for sleep. And something was just published today that really kind of poo-pooed cannabis for sleep. But the worst culprit is THC for sleep. CBD may have some benefit,
Okay,
either
and then,
with RLS or without RLS.
okay. Well, I'd like to thank you for your presentation. It was very informative, and I appreciate everyone joining us online today. We had almost 450 people and over 900 registrants. So Jackie, you broke the record. And we look forward to having you with us next month for our upcoming webinar. So if you go to our website, rls.org, and check out education events, you can, and get involved, you can sign up for future webinars. Take care and have a good afternoon, everyone.
Thank you so much for attending.